both being in our 50s and having gone through menopause, it also makes us appreciate what patients are saying when they come to us and say, I'm sweating through a meeting, or I can't focus as well as I used to. Nothing that we prescribe or that patients take, whether it's natural, supplements, over-the-counter, or prescription, is without some risk. Everything with benefit has some risk. Kristin, thank you so much for meeting with me a second time to specifically go over. Thank you. To specifically go over the benefits and risks of hormone therapy, and also new emerging medications that are options for our patients.
Yeah, sure.
One of the most obvious benefits of hormone therapy is relief of vasomotor symptoms. And hormone therapy, compared to any other type of therapy, reduces hot flashes by, I think, was 75% compared to other options. It also helps improve genitourinary symptoms. Both the systemic and vaginal estrogen can help reduce vaginal dryness, reduce pain during sex, which translates to improved libido, and reduces urinary urgency and urinary tract infections.
Yes.
Regarding bone health and fracture prevention, in the Women's Health Initiative, estrogen alone or estrogen plus progesterone both reduced overall fracture by more than 20% and hip fracture by more than 30%. I think the estrogen alone arm had slightly better data, but both of them had fracture risk, fracture reduction data.
Well,
I think you mentioned in our last conversation.
Yeah.
I'm sorry, go ahead.
No, I'm just glad you said that, because I do get some patients that are not on hormone therapy, and we find they have osteopenia or osteoporosis, and they ask me if putting them on estrogen would be the benefit. And I'm glad you said that about helping to prevent, not to treat.
Yes. Yes.
These conditions.
And for diabetes risk reduction, both estrogen only and combined estrogen and progesterone therapy were associated with reduced diabetes incidence. This is not to say that it was a causal effect, but there was an association.
Correct, yes.
Colorectal cancer risk reduction, combined estrogen and progesterone therapy was associated with the reduction in colorectal cancer cases compared with placebo.
Yeah.
Breast cancer reduction, estrogen-only therapy in patients who have had a hysterectomy was associated with a reduced risk of invasive breast cancer over long-term follow-up. And then cardiovascular benefit with early initiation. There was reduction in coronary disease and all-cause mortality when hormone therapy was started in younger women, specifically below the age of 60 and within 10 years of menopause.
Right.
Were there any other benefits or any comments on those benefits?
I mean, there's always the je ne sais quoi, people telling me that they don't feel like themselves. And so I think, and fatigue's a common thing. Now, this is not data. This is just how they're telling me they feel. And I think we touched on this last time, that I just believe so strongly in the power of restorative sleep, in regard to brain function and just our overall mood. So those are just the other things that I think a lot of my patients tell me, that they just feel more like themselves. And again, that's not in the Women's Health Initiative or any other study, but
that's quality of life.
Correct. Yeah.
Thank you.
Yeah.
And so can you outline some of the risks of hormone therapy? Because nothing that we prescribe or that patients take, whether it's natural, supplements, over-the-counter, or prescription, is without some risk. Everything with benefit has some risk.
Yeah, of course. The big, what we might call contraindications, or the reasons why we wouldn't use the estrogen for a patient, are also part of the risks. So the increased risk of what we call venous thrombotic events, meaning blood clots in the deep veins of the legs. These blood clots can mobilize and go to the lungs. That's called a pulmonary embolism. we can see stroke, which again can be blood clot mediated, like an ischemic stroke. So estrogen, I think just the easiest way to describe it is it can make the platelets sticky. We call that being a prothrombotic. And so if you already, as well, if you already have issues like high cholesterol, nicotine use, uncontrolled diabetes, poorly controlled hypertension, then you are going to have these extra elevated risks when you add estrogen on top of that. But even by itself, it does have an increased risk of stroke, heart attack, and blood clots. Other reasons, like I said, we have to be cautious again would be those things that would add fuel to the fire, right? So that would be, out of control high blood pressure, out of control diabetes,
Smoking.
oh gosh, smoking makes us nervous. And so in those patients especially, we're going to really make sure that we're using a transdermal preparation compared to oral. And then we're going to really rely on our primary care colleagues, to partner to try and see what can we optimize? Can we bring those blood pressures down? Can we bring the blood sugar into control? And I think also, we may have touched on this last time, but really one of the biggest things I think is underemphasized during this transition time is that this is a time where we really want our patients to grab the reins of their own health care, right? To understand that this is the time in our life where we're losing bone mass the quickest. And so this is when we have to redouble our efforts on weight-bearing exercise. Yes, there are these wonderful associations with hormone therapy, like the decrease, with estrogen only, the decreased risk of diabetes, well, especially with estrogen only. But then you can negate that if you're not eating whole foods, right? If you're eating overly processed things. So in an ideal world, right, we would have this great menopause center, and they do exist.
Yeah.
Where a patient could see a nutritionist, a trainer, you, me, all in one. Maybe that's a plan.
I just found out that UVA has a center like this. That's
they do, yeah.
Kind of a multidisciplinary center for women going through perimenopause and menopause.
Yeah.
It's exciting.
And I think a lot of us, I think from a fundamental viewpoint, I think most of us in our hearts know what we're supposed to do, how we're supposed to be nutritionally. I think a lot of, vegetable dominant, I think that's pretty intuitive. So, sometimes I have to have more in-depth conversations with patients, but a lot of times it's just hey, that estrogen that you had endogenously coming out of your ovaries is now gone, and I cannot replicate that. Yes. I can give you hormone therapy, and there are positive associations, but I can't replicate what estrogen's been doing for you all of these years. And now it's time that we have to double our efforts on our responsibility to our own bodies, being good stewards to our bodies, right?
Yes.
Yeah.
Yes. Just like we realize, the older we get, the same injuries just don't resolve as quickly or as well. So.
Yes. I think I told you I had a hip replacement in January, and I think to myself, it was not the easiest thing. And I think to myself, it gave me a whole level of empathy for patients, for my patients that are older than me that are having this done, because, I was this is not the easiest thing to do. So yeah, it just makes you refocus. Yeah.
And I think for you and I, both being in our 50s and having gone through menopause, it also makes us appreciate what patients are saying when they come to us and say, I'm sweating through a meeting, or I can't focus as well as I used to. I can't sleep as well as I used to. So it is definitely walking a little bit in a patient's shoes changes our perspectives a lot.
It does.
I remember I used to, when patients would call, after hours, and they'd have urinary symptoms of an infection, I would, early on in my career, I would be like, well, it's always best that we have a culture first, so go to urgent care, get a culture. And then I experienced a UTI, and I was like, what the hell? This is horrible. This is like shards of glass. I can't pee. And after that, had a very different approach to
Approach.
people
Yeah,
calling after hours.
I know it is
Um,
hard. Um,
can
yeah, I was
is
just going to
that is
go,
that it? Go ahead.
but we're just going to talk about alternatives because I think
Yes,
that was
other
part of your
yes,
original question.
yeah.
So let's say I
So
have a patient.
newer medications that are out there. Is that
Yeah, so we're really, this is a great time to be perimenopausal. We finally have, several years ago, we finally, a medication was developed that helps with the hot flashes and night sweats, or what we call vasomotor symptoms. It's completely non-hormonal. It works at a much deeper level in the hypothalamus at our thermoregulatory centers. And that first medicine was called Veosa. And so I think Veosa fills a very important niche. Now we're on our second generation, as I like to call it. We have Linquet available that works on not just one receptor in that thermoregulatory area, but a second one as well. And so it has a ton of safety data in regard to use in breast cancer survivors or women that are being treated for breast cancer, because again, it's not a hormone, not a sex hormone. It's not estrogen, it's not progesterone. And so I also use this medication in people that have significant risk factors for cardiovascular events. You know, if I have somebody that's maybe an has in and out atrial fibrillation, and I'm worried about blood clots. Other patients where, you know, again, maybe the blood pressure is like 180 over 100 something, and she's already on 2 or 3 medications for that. You know, maybe somebody that is has really bad triglycerides, or, you know, high lipids, smoking, like, again, anything that would would add fuel to the fire of potential side effects. Now, these medicines, again, only help with hot flashes and night sweats. They don't give you the vaginal benefits. They don't give you the bone benefits. But they do help you sleep through the night. And Linquet has studies showing superiority in regard to sleep compared to the first generation of these medications. So that's one of those things where if my patients are telling me they're really struggling with sleeping, although its predecessor is more readily available, sometimes I'll prescribe Linquet because I think I need to really focus on their sleep. And the company that makes Linquet has partnered with a specialty pharmacy. And so for the vast majority of my patients that get it through the specialty pharmacy, the copay, I think it's like $25, provided they have commercial insurance.
Oh, that's amazing. And then
Yeah, it is.
is there a way to get it for Medicare patients?
Now, so this is, so I don't participate with Medicare.
With Medicare, so okay.
I don't.
Okay.
I see
right.
Medicare patients, but
Uh-huh.
we don't participate with the insurance. So sometimes we do have to navigate those waters. And I'll be honest with you, I'm not good at that.
And can you touch on Duovi, which is
Yeah.
one of the other kind of newer for me medicines?
Yeah. So Duvi's actually been out for a while. And what happened is that it was the packaging Duovi was in was not keeping the medicine stable. So it was voluntarily pulled from the market. And then the company that made Duovi was very active in COVID vaccine development. And so I really feel like, you know, at that point, Duovi took a back seat for quite some time. They did address the packaging issue. And so it's been back on the market for just a couple of years now, but there was a period of time where it was not available. So as we've discussed, estrogen, if you have a uterus, has to be balanced with something to protect the lining of the uterus, because otherwise estrogen will stimulate the uterine lining, cause bleeding, and if it's continuously unopposed, it could lead to cancer. So we know that we have to balance it with something, and that something could be traditional progestogen, like micronized progesterone. It could be progesterone in the form of an IUD, like Mirena or Liletta. In Duovi's case, it is using beta-doxepin to balance the estrogen. And beta-doxepin is in this family of really intriguing medications. They're called selective estrogen receptor modulators. And what that means is that they work on estrogen receptors selectively in different tissues. Okay, so a cousin to beta-doxepin is tamoxifen. We know how tamoxifen works to block estrogen at the breast. That's why our breast cancer survivors who are estrogen receptor positive will be offered that. There's a cousin called raloxifene, and it actually helps with osteoporosis. It's a daily medication for osteoporosis. Beta-doxepin seems to be a hybrid of some of those. There have been a few studies looking at using beta-doxepin a little bit like tamoxifen in selected breast cancer patients. And so our suspicion has been that the combination of estrogen and beta-doxepin could in some way potentially be breast protective. So if I have somebody that really, really wants estrogen, but they have a family history of breast cancer, now provided it's not an unusual, like a premenopausal breast cancer or a known genetic mutation predisposing the patient to breast cancer, this combination is wonderful. Okay. Because it's going to give them the benefit of the estrogen, but potentially mitigate the breast risk. Again, it's on its patent, so it's not necessarily always available for everybody. But there are cost savings program if you go on the DuoVi website and you enroll in the program.
Okay.
Yeah.
Well, that's very helpful. That's very helpful.
So we normally use estradiol because that is what we call biosimilar. It's the same structure as what our ovaries made, estradiol, and it's the most potent of the estrogens that we make. And so it works well, and that's great. But there are some others. You have conjugated equine estrogens. Now, that is when you look way back in the Women's Health Initiative study, they were looking at Premarin. And Premarin, if you break down the word, is pregnant mare's urine. Mm-hmm. And that's where you get these multiple conjugated estrogens from the urine of pregnant mares. So I do occasionally get some patients that might want a mammalian source. They're like, hey, I don't want something synthesized in a lab, even if it is biosimilar to what I make. I'd really rather get something fresh off a mammal. I get that.
Really?
Yeah. And then I get some patients that come in, they're like, I don't want the stuff that comes from those pregnant horses. I'm like, okay.
Yes. So pretty much all our mothers were on Premarin.
Indeed. And so that's part of where a lot of our women, the data came from early on, was on Premarin, which is the estrogen by itself for women that didn't have a uterus, or Prem Pro, which was those conjugated equine estrogens and medroxyprogesterone acetate. So that's where all of the information that came out early on about the safety or lack thereof and how that study was misinterpreted badly.
Yes. So a combination of factors that made some of the data from the Women's Health Initiative not as useful today.
Yeah, and I think we did talk about this last time. The study, because they didn't want there to be bias, they used a patient population that really wasn't having hot flashes and night sweats to begin with, which is not the population we want to use. I think the average age was like 60, maybe 62. Again,
yes.
Don't quote me on the deets. But we found out that's where it comes to where you said earlier that we really want to initiate hormone therapy at the right point in somebody's life, not 10 years from their final menstrual period or 60 and above. Mm-hmm. Because then you can see the associations aren't there. And maybe there are some concerns about, the dementia data if you start it late in life. So again, you just have to be cautious. In the pipeline, there is a medicine, an estrogen coming out called estetrol. And it is what we call E4. And it is the predominant estrogen that we make when we're a fetus. And it's available now in a combination oral contraceptive pill. And so far, the thought is that estetrol is cleaner than the estrogen and the ethinyl estradiol in a birth control pill in regard to some of those side effects. like the the thrombotic risk, like blood clots, hypertension, that kind of thing. There's a company that's in the process of combining estetrol with micronized progesterone. So when
Amazing.
people say to me, nobody's studying this stuff, I actually get a little frustrated because I'm like, no, they are. I think
Yes.
people are just talking more about it. It's not like it's been
Yes.
stagnant. You've got Duovi, Viosa, Linquet, and then this mystery drug coming down the pipe. So, in
Yes.
the last decade, some things have really come to fruition.
Which is exciting.
Yeah, it
It's
is. It's
exciting
nice to be
for
able to
women
offer
going through.
patients something that we know works. And there are a couple other things that still do hold the test of time, like gabapentin at nighttime. Gabapentin
Yes.
taken at nighttime for patients that have strict contraindications to estrogen use. I didn't mention that with Viosa and Linquet, its risk, sorry, I skipped this. Its risk is it can cause liver dysfunction. So that family of medications, you do have to follow liver function tests
Okay.
per the manufacturer's instructions. With Linquet, it's every 3 months for the first
Okay.
year.
This is kind of what I wanted, just to summarize benefits, risks, and new options for women.
Yes.
That's
And
perfect.
I do think, I appreciate you saying earlier, like the association versus causation, because that's the other thing that I get patients that come in all the time. They're like, oh, it's going to lower my cardiovascular disease. I'm like, well, there's a lot to it. I mean, there's an association, and okay, so dating myself, back in the 90s when I trained, we were giving estrogen to women with the thought that we were going to prevent cardiovascular disease.
Yes.
And then
Yes.
the data kind of came around. Everything seems to be a little circular. So then we had to stop saying, I'm, not giving it to you to prevent heart attack and stroke necessarily. So, we were giving it to people that actually may have had higher risk because we thought we were going to be able to decrease that risk.
Yes.
So
Yes.
again, it's
And so, and I guess we do have to be careful when we're prescribing it, not to say we're prescribing it to prevent some chronic illnesses. We're treating your symptoms,
right.
and these are some potential benefits and potential risks, but
Right.
ultimately we're treating your symptoms.
Right.
So,
Yeah. And just as data continues to emerge, I think that, and people like us and influencers are talking about the benefits of estrogen. I do think that there are a lot of women that unnecessarily have been denied hormone therapy in the past. And that, like that generation, it feels like a travesty. And we can't turn back time. Like I said, there were just some providers that were just so phobic of, or just maybe didn't keep in the loop to understand the faults of the Women's Health Initiative. Anyway, it's just tough. But I think
Yeah.
now so many more people, like a lot of the patches are on back order. It's like you really
Because
have
so
to
many
shop
women
around
are-
to find it. Yeah.
yes. Yeah.
Yeah.
Yeah. No, that's true. That's true. Well, thank you again, Kristen. I think
Well, you're welcome.
think
It was
that's
good
all
talking
I
to
needed.
you.
Nice talking with you.
All right,
Have a great rest of your evening.